So today's our focus is primarily on to discuss few MCQs that were given in over the past few years in University of Colombo regarding the biochemical paper. So in this, where I would primarily be going through some of the statements that are given, and will not be going deeper into some of the theoretical facts. However, we just going to give a little bit of information regarding some of the topics here and there. Right. The first MCQ is about enzymes. So the statement here, what they try to illustrate is about Km. Now, before doing anything, just try to bring up the fact what Km means. Now, if you can remember, by definition, we know that Km is something to do with the affinity. It's actually the inverse proportionality of affinity. Now, once an enzyme has a higher affinity or an attraction towards the substrate, what would happen is that regardlessly, the Km value of that particular enzyme would be low, which means higher the affinity, the lower the Km value. So it shows an inverse proportionality. Now, if you draw a plot where the graphical illustration would show that the velocity of the reaction is dependent on the substrate concentration, it will show of a hyperbolic curve. Now, Km value is in fact the concentration of the substrate in which the enzyme has half the maximum reaction velocity. So if we assume that the reaction velocity of this enzyme is Vmax, the concentration of the substrate at which it has is half the value is known as the Km. Now, what they ask in this statement is Km is defined as the rate of constant for the formation of enzyme substrate complex divided by, so formation means, now let's assume that there are this is the substrate will react to form the product. The forward reaction is defined by the reaction constant K1, whereas in an usual the enzymatic reactions are reversible. So what would happen is that the products will react back to form the substrate. The substrate constant is given as K2. The equilibrium constant is K1 by K2. That is something that we know through our chemical kinetics as well. So substrate, now what they ask is Km is defined as the rate of constant for formation of enzyme substrate complex, which means K1, divided by the rate of constant for breakdown of enzyme substrate complex. P can also be uh, uh, stated as the enzyme to substrate complex. So what would happen is that ES is broken down back to form the substrate. So intermediate of ES is the ES will form products. However, this can go back. So what they ask is what does K1 to K2 ratio means? Now it has nothing to do with the uh, the Michaelis-Menten constant or the Km value. It is the equilibriate constant. The equilibriate constant is dependent on temperature primarily and certain other environmental factors as well, but it has nothing to do with Km. Km is completely dependent on the enzyme and its active site. It has active site, so it is the value of the Km is dependent on the type of the reaction that takes place. It has no associations whatsoever with either the enzyme concentration or the substrate concentration or any other factors as well. But it has some associations with temperature because the active site might undergo certain denaturations or certain processes where it will show different affinities towards the substrate. So nothing much. Km the first statement that is given here is a false statement, right? What does allopurinol means? Now, if you can remember, now the second statement is allopurinol is a competitive inhibitor of xanthine oxidase. Now, bit uh, it might the this is actually a drug that comes in treatment of gout. Now, if you can remember what gout means is there are instances where you would see increased levels of uric acid or hyperuricemia. These crystals will get deposited in certain joints. This will especially in metatarsophalangeal joints and even in smaller joints regarding interphalangeal regions. However, once these crystals gets deposited, it causes inflammation and cause a certain disease which is known as gout. So now, if you can remember, what usually happens is nucleic acids, especially nitrogenous bases with purine, are broken down in a series of reactions where it finally forms uric acid. The production goes through few chemical intermediates. Now, I'm not going to elaborate it much, but there is something called xanthine, then there's something called hyperxanthine, and then primarily it breaks down to form uric acid. This xanthine molecule, this dissociation of the xanthine molecule is dependent on an enzyme which is known as xanthine oxidase. So once there are ample amount of purines, this might be because of excessive intake of consumption of DNA containing material, especially animal food. For an example, people who eat uh, beef and meat products usually tend to have a susceptibility towards gout. Now, this is because it has so much of DNA. DNA means the presence of purines. Purines has to be broken down. It is broken down to form uric acid. Once the amount of uric acid is excessively high, what would happen is there will be hyperuricemia in blood. So, hyperuricemia will lead to the formation of gout. So, people who have gout have high uric acid levels. So, to limit the uric acid level, the formation is reduced by means of using allopurinol. What does allopurinol use? It inhibits xanthine oxidase in a competitive manner. In a competitive manner. So, what are the now? So this is something that you need to remember. Allopurinol causes xanthine oxidase uh, inhibition. So it's a competitive inhibitor of xanthine oxidase. For an homework, what you could do is that think about the conditions where the uric acid levels would be elevated, where the I just mentioned one where it is the hyperuricemia due to excessive meat consumption, but there could be a few others as well, such as for an example, people who are having tumor, who have undergone chemotherapy is also susceptible for the formation of gout, because now there is a higher catabolism of DNA, higher turnover of DNA, because excessive production of cellular division is characteristic of cancer. So hence what I would see is there is a possibility that there will be higher DNA degradation, which will lead to excessive purine degradation and formation of hyperuricemia, which will lead to gout. So by all, there are many mechanisms where gout is a possibility. I need you to go through them, and allopurinol is one good treatment modality. Right. Of course, the other statements are not much very important. Calcium ions increase amylase activity. That's something that you already know, even through your A levels. So that's a true statement. And uncompetitive inhibition Km value in uncompetitive inhibition. So uncompetitive means non-competitive inhibition. So what happens in non-competitive inhibition? Something very in non-competitive inhibition. Now I'm just going to draw the graph back again. This is the enzyme where I have plotted it against the substrate concentration and the velocity. So with the non-competitive inhibitor, what would happen? The non-competitive inhibitor which will primarily uh, occupy the active site of the enzyme, preventing it from undergoing any reaction. For an example, let's assume that there are three enzymes. The non-competitive inhibitor, I'm sorry, it will occupy a site which is beyond the active site, and by doing so it will cause a conformational change of the enzyme. It will change its structure so that it will no longer have the capacity to bind with the substrate. So what would happen? Now this is a totally an enzyme which is non-functional. It will not bind with the substrate. Therefore, it will not take a part in enzyme substrate complex formation. So out of the three enzyme molecules, now only two are functional. Only two are functional. The enzyme which is bound to the non-competitive inhibitor is completely not active. So what would you see is that what you would see is that now only the velocity of the reaction reduced would be reduced because now only a few enzymes are coming into play. The total enzyme is not in action. The total quantity of enzymes is not in action, but does it has an influence on the active site? No. Why is that? Because uh, if it is bound to an enzyme, it will completely destroy the active site, but it will not have an influence to other enzymes where it is not bound. So the affinity of the active site will not change. Therefore, what you would see there will be no change in the there will be no change. This is Vmax 1. So this is Vmax 1 half the value. This is Vmax 2. So this would be half the value. So ultimately, there is no effect on the active site of a specific enzyme. Hence, you would not see any difference. So in a non-competitive inhibitor, the Km value is constant, but Vmax is lowered. Right. Amylase is present in the urine. Again, this is a statement which requires a little bit of knowledge on diseases. Amylase is elevated due to many circumstances, many diseases in the body. Now, where would you see amylase production? Either in the pancreas or the salivary glands. Now, tumors of the salivary glands will lead to increased amylase levels. That's something very not very frequently seen, but yes. But most of the time, increased levels of amylase levels in the blood is seen once there's condition which is known as acute pancreatitis or even chronic pancreatitis. In acute pancreatitis, there is excessive elevation of amylase levels in a very small period of time. And what you would see is that the serum levels of amylase is greater than 3 times the normal level. But in chronic pancreatitis, it is elevated, all right, but it is not as that of acute pancreatitis. Let's assume acute pancreatitis has something around 700 international units. But in chronic pancreatitis, it is more or less like 200s, the normal level being 100. So I'm just giving a rough value. There's something not to memorize, but this is what happens. Now, once there's excessive levels of amylase levels in the serum, this will get ultrafiltrated and pass through urine as well. Now, does it exclude the fact that urine might not have any amylase in a normal person? No. Normal person will have a small amount of amylase passing through the urine, but this is elevated in both acute pancreatitis as well as chronic pancreatitis. But in acute pancreatitis, the usually this has happened in a very short period of time. The patient will become very symptomatic. He will have exclusive abdominal pain with vomiting in a very short period of time, usually after consumption of alcohol. But under these circumstances, it is only present at a very short period of time. So there is not enough time or sufficient time for the amylase to pass through urine. So sometimes there is a possibility at the initial stage of acute pancreatitis, the urine level of amylase is not elevated, or it is usually in the normal level. But in chronic pancreatitis, usually what happens is there's the chronic means that the disease has been there for a long period of time, and um, this will lead to the presence of amylase in the urine elevated, and this has been continuous over the disease duration. So coming back to the first statement, amylase is present in the urine, absolutely correct, but the levels are usually elevated in chronic pancreatitis. So again, a true statement. So this is the first question. Now we'll be moving to the second question. The second question again about enzymes. The first statement says that the international system enzyme activity is measured in mu moles of substrate converted per minute in constant pH and temperature. Yes, enzymes means, now if I do not like to go back to the chemical kinetics because it's a bit sophisticated and sometimes you might not understand most of the facts. What if an elementary version is that whether a reaction takes place or not is dependent on Gibbs free energy, which is dependent on temperature and other constants as well. Now, for a reaction to take place, there is the necessity of the conversion of substrate to form products. However, during this conversion, there is the formation of enzymatic substrate complex. For this, there is a certain activation energy which is involved. The utilization of an catalyst or an enzyme, what it does is that it will have its impact on the activation energy and reduce it. But it has no influence whatsoever on the chemical equilibrium of the reaction. It will only reduce the activation energy, stabilize the enzymatic to substrate complex, and thereby increase the rate at which the products are formed. But it also will enhance the rate of reaction where the products are broken down to a substrate in a reversible reaction. So the again coming back to the statement, the international system where the enzyme activity is measured is given uh, in something which is denoted by the letter mu, and this is in fact the rate at which the substrates are converted to form products. So nothing very uh, it's not rocket science per se. So just as normal statement, we can consider this as true. The second involves a little bit of uh, understanding about diseases as well as diagnosis as well. So alanine transaminase levels. So what does this mean? Alanine transaminase means ALT is an enzyme which you would see in the cytoplasm of cells. In the cytoplasm of cells. What does it do? It is, I'll go to a new screen. ALT is present within the cytoplasm, right? So it is present in almost all the cells, but particularly in higher concentrations when it comes to liver. I usually remember this as uh, because of the presence of the letter L. The L means it has a higher specificity towards the hepatocytes. Now, disease and ALT levels are usually done in laboratory testing, where this denotes the if there's some sort of an injury to the liver cells or the hepatocytes. If there's injury to hepatocytes, then there's a possibility ALT would be higher than normal. Usually the normal ALT value is around 50 international units. So this would be greater in people who are having hepatitis per se. Hepatitis can come as many different modalities. One would be chronic liver cell disease. It could be fatty liver. It could be liver necrosis or liver breakdown, which is also known as acute fulminant liver disease. Now, there are multiple diseases which involves the hepatocytes. Now, others could be viral hepatitis, hepatitis B, hepatitis C, even A, viral hepatitis. And apart from that, there could be drug toxicity, which may have implications on the liver. The liver will be where the liver will not be liver will undergo some sort of a damage, and then there is a possibility of having a higher ALT. So in most of these conditions, you would see high ALT levels. So coming back, you would see alanine transaminase levels increase liver cell necrosis. Yeah, it's a true statement, but this is not what they will be looking for in the coming exams. In the coming exams, this might be a little bit enhanced, or some other prospects to ALT will be attached and you would be questioned. So I'm just gonna give you a complete understanding about ALT and other stuff as well. So ALT is done as a biochemical assay of liver function. This is not liver function test per se, but it is a sort of a biochemical test where we can have a rough idea about how the liver is involved. So ALT is not completely specific of liver cells. It is certain other cells which undergo this some sort of an insult can also lead to ALT increments. But in comparison, ALT is rather an enzyme which is found in greater concentrations in the liver. Along with this, there is another enzyme which we look for. It is called AST. AST again found within the mitochondria. It is found in the liver as well, but more or less now once it comes to biochemical testing, we ask for both ALT and AST together. AST is more or less present in red cells, muscle cells, which include the heart, the the kidneys, and even skeletal muscles as well. So, and even present in the liver. So, once there's some sort of an insult or a damage to either red cells or the muscle cells or the kidney, AST levels will be high. Now, the problem is a patient who is having a liver issue or a hepatitis will have both high ALT and AST. The parameter that we use to identify hepatitis from other tissue damage would be a ratio, ALT to AST ratio. Usually what you would see is that ALT levels being more than 3 times that of the AST values. So ALT being more than 3 times the value. So this is what we usually take. The ratio is what we usually consider. But however, there are a few other things as well where we like to incorporate when it comes to biochemical testing. But again, a smaller, a more or less an elementary version would be not both ALT and AST values, both would be high in hepatitis, but the ALT would be much greater than AST. Now, there are a few specifics as well. Uh, in chronic liver cell disease or CLCD, you would get this value, but in certain hepatitis, the ratio will not be seen, especially in acute fulminant liver diseases. But again, something not for you to memorize or take into account, but just know that it is not possible to come into conclusions with ALT and AST alone. Right. Organophosphate insecticides are irreversible inhibitors of creatine kinase. Now, what do we know? What do we know about organophosphates? Organophosphates are seen in OP poisoning, is seen in herbicides and insecticides. The real problem associated is the fact that some of the people use these chemical agents as a mode of suicide. Herbicides and weedicides, insecticides. Right. So what does organophosphate do? Organophosphate binds to an enzyme which is called as acetylcholine esterase. What does acetylcholine esterase do? It breaks down acetylcholine to acetate and choline. Usually this is present in the nerve terminals where you would see in the vicinity of muscarinic and nicotinic receptors. Now these are the places where you would see nicotinic receptors and muscarinic receptors, which play an important role in autonomic nerve system. Now I'm just not going to emphasize or describe about the autonomic nerve system and how it functions. You just have to go back to your physiology and at least have an idea about how this how the mechanism of the autonomic nervous system works. Right. So acetylcholine has its function on these receptors and carry it out specific deeds. However, the acetylcholine has to be, once the function is done, it has to be broken down. The breaking down process is carried out by acetylcholine esterase. However, what you would see is that once this enzyme is blocked, this is blocked by organophosphate binding into the active site of the particular enzyme. By binding to the active site, what it does is is a irreversible form of a inhibition, irreversible, so it cannot be reversed back. So it will bind and prevent the acetylcholine esterase from working. So what would happen? Acetylcholine will start accumulating at these receptors. Once this once these gets accumulated, there will be hyperfunctioning of the both nicotinic and muscarinic receptor, muscarinic muscarinic receptor pathways, right? So what you would see now, what does acetylcholine usually do? Acetylcholine has implications on the vagal system or the parasympathetics, usually parasympathetics, and few cholinergics, of the sympathetic system, especially regarding uh, pseudomotor or the action of the electropyroid muscles. Then there is the pseudomotor, and then there is the set secretion, and then um, so these are few of the things that are being carried out by cholinergics of sympathetic. So what you would see, there will be hyper functioning of these two systems, parasympathetic especially. Now once this hyper function, what you would see, you would see, now I usually I like to keep this memory sludge. This is how I remember. What does the parasympathetic do? It causes salivation. So you would see increased salivation. Parasympathetics are also involved in the formation of tears. So increased lacrimation. Sometimes even urination, urinary incontinence is a possibility. Diarrhea. Why? The parasympathetic of the vagus is involved in a peristalsis of the bowels. So the peristalsis takes place excessively, which will lead to diarrhea. Even excessive uh, sweat production is a possibility. And what else? Uh, G means GI discomfort, abdominal pains, and E means emesis, which is vomiting. So these are few things that you would see in opioid poisoning. Apart from that, there is a possibility the patient might be having bradycardia. Why is that? Again, the action of the vagus, and hypotension, bradycardia, hypotension, and there will be few others as well. Especially the nicotinic receptors that are found in the muscles will cause muscular fasciculations, and why is that? Because acetylcholine is the prime is the prime neurotransmitter which works at the nerve terminals of the motor nerves, where it sends information for the muscle activity to take place, or the muscle contractions to take place. But once this is present in excessive levels, what would happen is that there is uh, so much of stimulation for the muscle fibers, it will start to fasciculate, it will start to contract in such a manner, it will cause a little bit of a twitching. And also with the twitching, once this happens for a long period of time, there is a possibility the muscles will cramp itself. So these are some of the things that you would see in opioid poisoning. So what do we do? Now what do we do? We have to find a cure or a remedy. The problem was with the acetylcholine esterase. Now it has been irreversibly inhibited. Now we have to stay until the enzyme is reformed or it is resynthesized. So this will take around 2 to 3 weeks. But until that happens, what we should do is that we should try to make sure that the symptoms are mitigated, or the symptoms are we provide some sort of a cure for the symptoms. So what we would like to do is to, now there are different remedies. One would be atropine, one would be palidoxime. Palidroxine. Now what does palidoxime do? This will bind to organophosphate OP. After binding, what it does is that it reactivates the acetylcholine esterase. This is not very significant, but again has its function in symptom management. So atropine is the normal modality that we uses for the treatment of opioid poisoning. Right, enough of that. So organophosphate inhibitors are irreversible inhibitors of creatine kinase. No, it's actually acetylcholine esterase. Acetylcholine. I'm sorry, this is false. Acetylcholine. Lactate dehydrogenase level is higher in serum following a myocardial infarction. Yeah. Now this question is little bit tough. Uh, I have brought this as well. Now there are biomarkers. Simply, biomarkers means chemical constituents which we can utilize to quantify or qualitatively identify diseases. So biomarkers are used to identify diseases. This is what would happen. Now, if there is a myocardial infarction, MI, what would happen? There is cellular death of cells in the heart, of cells in the heart, or the muscle cells of the heart. So cardiac tissue. Ultimately, what would happen is that once there is cellular death, it will break, the cells will lyse and will release the chemicals that are found inside. So it will release these chemicals. Now, chemicals inside the cell. Now this moves into the blood, to the serum. If we can identify the presence of these chemical constituents in the serum, we will know that there is a possibility that this specific cell has undergone some sort of a trauma or an injury. Right. Now, for this to take place precisely and to diagnose the disease accurately, the the chemical constituents that are released to the blood should be completely specific to cardiac cells, to the myocytes. So usually what you would see is that even cardiac, now there's cardiac muscle cells and skeletal muscle cells. Both of these have the chemical constituents that are present in both of these cells are more or less similar to one another. So we cannot completely identify one from another. Now let's assume, now uh, once a cardiac cell undergoes some sort of an injury, it will release troponin. Yeah. The problem with troponin is that Now we will do a serum assay test and the troponin levels are elevated. But we do not know actually whether it's a where troponin that has come from some sort of a damage in the heart cells or in the muscles. Sometimes some sort of a rigorous exercise that has happened previously in the pectoralis major, which has led to injury in the pectoralis major, presenting with the chest pain, have high troponin levels. But how do we identify that? That's the question that comes into play. So it is like this. There are isoenzymes. So what you would see is the same molecule, same functioning molecule, but with different structures. The structure difference is quite subtle, but still can be identified chemically. So what you would do is that the assays are done for specific isoenzymes. These isoenzymes are more or less present in higher concentration in one cell rather than the other. So in cardiac cells usually have troponin I. There's a specific troponin I for the cardiac cells, so which is not very prominent in smooth muscle cells or in skeletal muscle cells. So usually what we use for in myocardial infarction is the assay of troponin I. Both troponin T and troponin C are not very specific. So for troponin I, where there are mechanisms to identify this troponin I, which is more or less specific to heart cells. Once troponin I is identified in excessive levels, we know that the problem is in the heart cells. So the injury has happened to the heart, so it could be a myocardial injury, given the given the clinical symptoms as well. Right. Now the problem is not with troponin I. The question has been asked of LD1. Right. So this is a high. There is something called high sensitive troponin I as well to identify myocardial infarction at a very initial state. So a biomarker will be will take a little bit of time. Will take a little bit of time for it to start to be present in the serum, and to peak itself, it will take further a little bit of a duration. Good. So now you would see troponin shows excessive levels in after about 1 day, specifically after about 24 hours, it will have its peak value. Then it will gradually reduce. Why does it reduce? Because now it is usually cleared off either by the liver or the kidney. Most of these biochemical constituents are broken down or passed into the environment. So with time it will reduce. But what do you see? Now the troponin level usually stays for around 14 days elevated. Now this is not accurate, but it will usually be more than 7 days, 8 days. So even now let's assume the patient has had a heart attack in on this day and even on this day. Now if you do a troponin I, the levels would be higher than normal in both these circumstances. But how would you identify? Again, even though troponin has a very high sensitivity, high specificity, and is a very accurate test of MI, you will not be very reliant on troponin once there are sequential myocardial infarctions. For that, you need a biochemical marker which will rise and settle as soon as possible. It will come back to its normal level. Now this is evident in an enzyme which you see in creatine kinase. But again, creatine kinase is not specific to heart muscle cells. Why is that? Because it is found both in kidneys, skeletal muscles, and small levels in other tissues as well. So not very specific. But does it has an important function in MI management? Yes. If the patient during the hospital stay says about a pain back again in a very small period of time, let's assume after 3 days, then you are capable of doing a creatine kinase levels just to identify whether there has been a reinfarction. So a sequential MI is more or less identified through creatine kinase. Good. Now we know about troponin. Now we know about creatine kinase. Myoglobin is the first marker to be elevated. The initial chemical constituent which will be released into the blood and will have a peak value as soon as possible would be myoglobin. But is it specific? No, it's not specific. Myoglobin is seen in both skeletal and smooth muscles. So, how do we know whether it's the problem is in the heart or the muscle? That's not very clear. So, myoglobin is not utilized in such a way. But again, if you ask which biomarker will have the quickest uh, uh, increment or the will be shown as soon as possible after MI, it's myoglobin within 2 hours. But but it is not very specific. That's why we use troponin. Even in troponin I is the one that is utilized, not COT. Good. Now the question asked about LDH. Yeah. Again, LDH also lactate dehydrogenase enzyme has 4 isoenzymes 1, 2, 3, 4. One is uh, usually present in heart. Two, two is usually present in blood cells, red cells. It could be red cells, it could be liver. So there are multiple in blood cells. Specifically, not red cells, the WBC. Red cells has something to do with LDH1, red blood cells, right? WBC. Then LDH3 is present in lungs, LDH4 in the kidneys and the pancreas. So these are isoenzymes which carries out the same function but different structure. The structure can be identified. So that's why it is important. Now, those days, in the good old days, what the troponin wasn't that very significant, and it was not something very widely available. Most of the time, the labs were dependent on LDH and other enzymatic modalities to identify as a biomarker, to be utilized as a biomarker for identification of MI. So what it does was, even though LDH, now there's a possibility in an MI there will be specifically higher levels of LDH1. LDH2 will also increase, but the problem is that LDH1 elevation is much greater than LDH2. This is because LDH1 is present in higher concentrations in regard to that of heart cells rather than other cells. Especially people who have hemolytic anemia, who have hemolysis, will also show high levels of LDH1 and 2. But LDH1 to 2 ratio would be very specific for myocardial infarction. Again, something that is relevant and close to that of ALT to AST. LDH1 to 2 ratio, if it is greater than 1, it means there is a higher chance that the injury would be specifically be at the specifically be in the heart. So that was identified. LDH costs less, it is more widely available. This is why LDH is utilized. Apart from that, it has very low sensitivity and specificity in concern of MI. So what happens? Lactate dehydrogen level is higher in serum following myocardium. Yes, both 1 and 2 are higher, but 1 to 2 ratio would be higher in myocardial infarction. So that is a true statement. The final one, regular alcohol consumption elevates the Gamma glutamyl transferase. This is denoted as gamma GT. Regular alcohol consumption elevates gamma GT. Again, now you see that most of the time what they do is that they ask questions from clinical scenarios. They are not very keen on asking about how biochemistry works. This is because our course is primarily based, or medicine is primarily based on clinical aspect. So rather than going into biochemical details, which is quite which is done in other biochemical universities where you study about biochemistry, it is not our concern right now. What we will be looking for is the clinical aspect. So this is why such questions appear. Now, the liver, I said, the hepatocytes, once hepatocytes are damaged, you will see increased levels of ALT, AST, ALT to AST ratio would be higher, 3 or 2. Right. Now, the other problem is, now there are few other biochemical assays that we can do. One thing would be ALP. I will then in the next video I will be looking at ALP, but here I'm not going to say much about it. ALP is found both in liver and bone. The other would be gamma GT. Gamma GT is primarily present in the liver as well as the biliary system. Now this is a enzyme that is found over the cell membrane, and this is more or less present or elevated in the blood once there is some sort of a obstruction to the biliary tract. When once the biliary tract is obstructed, there will be stasis or stagnation of bile. This is known as cholestasis. Once there's cholestasis, it is not even in the extrahepatic bile ducts, but also in the canaliculi that are found within the liver as well. So the small canaliculi, bile canaliculi, produces gamma GT. If there is potential, if there is some sort of a threat or an injury or an insult to either the biliary canaliculi or else the biliary system, what it does is that it will have increased levels of gamma GT. What you would see is elevated levels of gamma GT. So in cholestasis, let's assume that there is some sort of a blockage in the extra hepatic biliary duct, which could be due to docolithiasis, which means now there's a stone in the biliary tree. There is cholestasis, so there will be increased levels of gamma GT. But what of alcoholism? Alcohol will have an implication of the biliary canaliculi within the liver, which will lead to a sort of a cholestasis that can increase gamma GT levels. So once a patient comes with mucosal color changes, specifically now there's an entity which is called jaundice. In jaundice, what you would see is this: there's yellowish coloration of the body, especially the skin as well as mucosal surfaces. This is because of the deposition of bilirubin. Why deposition of bilirubin? It's because bilirubin is carried out through the bile system, biliary system. If the biliary system is blocked by any means, there is a possibility the bile would flow into the serum and then be deposited elsewhere. And also, the biliary system will conduct only bile that is conjugated. Now, once you do your gastrointestinal system, the physiology, you will come across these terms and the pathophysiology. So the biliary duct will conduct only conjugated bile because it is the only form of the bile that is it's the only form of bilirubin which is soluble in water. So if the conjugation does not take place, there's a there are insoluble bile pigments which will pass into the blood and then cause jaundice. So this could be either due to excessive levels of conjugated bile, which we call direct bilirubinemia, which is because of cholestasis. There, because of the there's a blockage in the bile ducts, or else this could be due to a hepatic cause where there is lesser conjugation, and therefore because the conjugation does not take place well, it cannot be secreted into the bile ducts, and henceforth this non-conjugated bilirubin will pass into the serum, causing jaundice. So it is called indirect bilirubinemia. In both of these circumstances, what you would see as a manifestation is the presence of jaundice. So in jaundice, once a patient comes with jaundice, we usually ask him to get these testing done. We do, of course, we do an ultrasound scan to identify whether there is any sort of a biliary block. But before doing the ultrasound scan, we would like to get some biochemical testing done. Here we would ask for an ALP, a gamma GT, and a bilirubin. The bilirubin level will be elevated with it could be either direct bilirubinemia or indirect bilirubinemia. Direct or indirect. Indirect means unconjugated. If it is unconjugated, then of course the chances of having a biliary block is quite low, because the problem is within the liver. The liver is not working, it is not conjugating the product. It's not because some sort of a stasis. So uh, you would not get in indirect bilirubinemia, you would not get high high gamma GT levels. Gamma GT would be usually normal, and ALP levels could either be high or normal. But in a sort of a obstruction, it could either be in the canaliculi, or it could be in the extrahepatic biliary ducts. What would happen is that gamma GT would be elevated along with direct bilirubin levels. The ALP would also be elevated, but ALP is not very specific of obstruction, because ALP will be elevated to any trauma or an injury that happens to the liver. The problem is it's not so. The gamma GT is more or less more specific to biliary system rather than the liver. Therefore, any obstruction, there's a higher possibility of having a gamma GT, high gamma GT value. Again, ALP can be um, it can be quantified. With the quantity, you can come into a conclusion. Usually something more than 1,000 will denote or signify a possibility of a cholestasis or obstruction, and something in between 100 to 1,000 will could be due to some sort of a liver injury or even bone. So again, I'm not going to relate much of the information about LLP, but it's just that it can be elevated but not very specific. But once gamma GT is elevated, we can come into a conclusion, yes, it might, there is a higher possibility that there might be an obstruction in the biliary system. Good. Now, if the gamma GT is elevated, we do an ultrasound scan, identify this obstruction, and treat it. But the problem is this: sometimes you have gamma GT, but still the ultrasound does not show any stone. You do an other invasive test, and still there is something called ERCP, not important right now. Again, still no stone. What could have been the problem? It's because the patient might have been an alcoholic in the he might have been an alcoholic in the first place. Alcoholics usually have elevated gamma GT. Even after abstinence, even if you stop taking alcohol, it will retain to more or less like 3 to 6 months before going down. So doing a gamma GT will not be very significant. It will not provide you much information if the patient is already an alcohol abuser. Are we good? So gamma GT is elevated in regular alcohol consumption elevates gamma GT activity. Yes, in a chronic alcoholic, there is a possibility that this might be true. Right. So this is it. So I have gone through two questions in a very informative manner. Make sure that you go through these two and relate with your answers as well. Uh, I'll do another enzyme tutorial. Now I have identified few of the some of the good questions that were there, and I have done a little bit of a discussion and an analysis sort of a thing. But I'll go through further questions as well if I find something very more interesting and something that need to be discussed. I will be doing that in the later sessions. So thank you, and we'll meet next time.